Today is our third webinar, and as the first two have been, they have been fantastic, and I expect no less. And I look forward to an engaging and informative session today. It is a privilege to introduce these two lady surgeons I've known personally for some time. The first is Miss Ayesha Noorani, who is actually in the Department of Esophagogastric Surgery at the Cambridge University Hospital. We work in the same department. She's my senior at work. She has her PhD. She's also an academic lecturer at the University of Cambridge School of Medicine. And the second speaker is Dr. Anita Eseenam Agbeko, who's also a PhD holder. She's a specialist general and vascular surgeon at the Confanosh Teaching Hospital. She was actually in the last couple of years, 2-3 years, she was in the UK as an international fellow studying vascular surgery at Imperial College and I think at St. Mary's as well. We are really, really excited to have them both speak to us today, and I can't wait to hear them. So without much ado, I would invite Miss Ayesha Noorani to start her presentation. Thank you very much. If you can mute whilst you're not speaking, that would be great.
Hello, everyone. Can you hear me all right? I'll take that as a yes.
Yes,
we can hear you.
Lovely. Thank you so much. It's an absolute pleasure to meet you all virtually. I'm just going to get my slides up. Give me 1 second, please. Okay, well, thank you, Theo, for that lovely introduction. It's pretty noisy where I am as well. I've got 2 young ones in the background, but I don't think it's going to be as noisy as Theo today. So it's my absolute pleasure to give you a little overview of ethical considerations, gaining study approval and undertaking patient consent. I hope to point you towards some useful resources which can help you while you design your own studies, give you a few examples and some inspiration, and I'd be delighted to take questions in the end. So as Theo already mentioned, a little bit about me. I'm a esophagogastric surgeon, so I'm trained as a general surgeon, and my subspecialty is esophageal and gastric cancer. I'm also a cancer researcher, so my clinical work is based in Cambridge, in the same hospital as Theo, in the Agbeko Hospital. But my cancer work is very much cancer genomics and whole genome sequencing. And I'm really quite passionate about translational research, which is truly bench to bedside. So it's a real opportunity to design experiments based on human tissue to answer very pertinent questions, specifically targeted in cancer research and improving patient outcomes using personalized medicine. And all of that research is very much now based in the Wellcome Sanger Institute, which is a sort of a state-of-the-art sequencing center based in the United Kingdom. My first sort of taste with designing a research study was a randomized controlled trial. I was a junior doctor, so maybe a year after my qualification, and I took that on as a chief investigator, and it looked at fluid restriction in the context of major vascular surgery at that time. It was a fantastic opportunity, and I guess the one thing it made me learn is not to shy away from opportunities. You know, a lot of the time you think you can't do something like that because you're quite junior, but actually if you have the right support, the right questions, you should really use these opportunities and just go for it. During my PhD, I had extensive experience in designing quite complex research studies. I set up what was then the first rapid autopsy study in the United Kingdom. So to explain that, my interest was looking at evolution of cancer from diagnosis to death. And to answer that question, I set up a study where patients donated tissue for research. And that's mine. Excuse me 1 second. So So I set up the study to actually look at tissue from diagnosis to death in what was then the first rapid autopsy study in the United Kingdom. So within 6 hours, patients had to have an autopsy, have extensive sampling, and that tissue was then subsequently submitted for whole genome sequencing. So that was a huge collaborative effort. It wasn't just myself, it was a big team of palliative care physicians, of surgeons, of pathologists, of patient advocacy groups. So really all of that to make that happen. And that work resulted in a paper, which I'm very proud of, but the main reason is because it was a huge collaborative effort in designing a very complex ethical study, but it resulted in a very strong body of work where we showed, as published in Nature Genetics, a novel model of esophageal cancer spread. After that, I've sort of continued down the line, and I've carried out 2 further studies, both sponsored in the Wellcome Sanger Institute, and my work is both global, so in a lot of it in South America as well, and in Europe, and also locally. I'm a chief investigator, so I'm leading the studies, and a lot of the work that I do is based specifically in whole genome sequencing, which has its own ethical considerations, which I'll talk about in a second. So really, I think when you're looking at designing studies, it's very good to look at some resources that are available. In particular, in the GMC, there's good research practice, and it sort of outlines the main points that are really important when you're embarking on such an endeavor. Number 1 is looking at law and governance. I mean, is your research legal, which sounds quite obvious, but of course you can't be using a medicinal product which might be illegal in the country that you're based. So number 2 is to really look at the research design and practice. And over here in the UK, we always have to submit our study to an ethics board, which would be the same. The principles are the same wherever you are. But essentially, you want to make sure that that study is appropriately powered. It has the right statistics, the right design to answer your research question. And that research question has to be relevant and be answered by the study that you're designing. And in the UK, that's called an IRAS sort of system that we have to show that. So you have to have the right people involved, whether it's statisticians, scientists, clinicians. It's all got to be thought about in a very structured manner. Of course, you want to make sure you want to protect your patients from harm, for example, unnecessary investigations like a lot of radiation, which may not be appropriate. And if you do need radiation, then you've got to go through an appropriate pathway. It's important to have honesty and integrity in your research. And then in terms of consenting for research, it's important that it's informed, so patients actually understand what is it that you're asking them to do, and that it's taken by an appropriate person who can consent them for the procedure, and I'll come on to that in a second. It's important to avoid conflicts of interests, financial or personal, which again sounds obvious, but these things are often missed. And it's really important to respect confidentiality, and there's different types of specifics in terms of the confidentiality. One is looking at data protection, which is very important with the GDPR. Data management, because all of the data that you collect, especially in translational work, is you have human samples and they have to be anonymized and pseudo-anonymized. So essentially the people who are working on them can't trace the origins to protect the confidentiality of patients, and that's super important. And also how you're going to store all that information. It has to be in secure servers. So it's again, all of these things have to be taken into account quite seriously. And in our institute, we have a data management team because we're dealing with whole genome sequencing, and you need that extra level of security. But I think even for all clinical studies, if you're going to store data for participants, it has to be done in your hospital secure servers. Data has to be in locked cupboards, etc., so that you protect this at all times. You could have specific considerations with the data type. If it's whole genome or if it's clinical research, it still all needs to be protected, and you've got to store it in a safe manner. The GMC also talks a little bit about, again, consenting for research. And again, this touches on the main points, and it's a good framework to follow. Your consent's got to be valid, in terms of adults versus children. Does your participant have capacity to consent? So one of the studies that I'm involved in has patients who cannot consent, because they are too unwell or they're intubated in intensive care. And for them particularly, we have a sort of way in the UK that you have a designated consultee. So you have a next of kin who can consent on their behalf, and that's called consultee research. But essentially the patients, when they regain consciousness or regain capacity, then always have the right to refuse. So if you've collected tissue under the specific consultee research pro forma, then you can still, they still always have the right to withdraw at any point once they regain consciousness. So patients always have a right to withdraw. You've, again, data sharing between institutes, and again, you have to consent for all of these things, to tell them how specifically their data will be used. Will it be used for other studies only? These things have to be really quite well spelled out from the start. You've got to give them information in a way that they can understand and fully comprehend. So you've got to avoid the use of medical jargon wherever possible. And you've got to take responsibility, as you do as a doctor in your day-to-day life, for seeking consent, like you do for surgical procedures. It's much the same for research. Specific considerations are children. In the UK, for medical procedures, children can consent over the age of 14. It's a law called Gillett competence. But in terms of ethics, for the purpose of research, they have to be 16 and over. Again, in terms of capacity, there's a Mental Capacity Act in the UK in 2005 that we use, and you'll have your similar legal procedures in place in Ghana. But again, next of kin can act, but then they need again, it's a completely separate pathway and something that has to be agreed with their next of kin, but the patients always have the right to refuse. Research involving human tissue in the UK comes under the Human Tissue Act, so the storage, being able to trace samples, store them securely and also anonymously to protect patients' identity. Again, that was all covered by the Human Tissue Act. And then the thing with whole genome sequence data is essentially you can identify people, you can't identify them to a specific person, but we all have our own unique genomes. And there's always a question of what if you're looking at a particular disease, but you pick up something else. So you have to consent patients to make them understand what you're looking for, if that's going to be relevant, because essentially it is identifiable data. And you can pick up other diseases, but that's often not the focus of the study that you're doing. So these things are very clearly explained in consent forms and patient information sheets. The other thing that's really important is good clinical practice, and that's an NIHR, so the National Institute of Health and Research based sort of resource, but everyone who consents for any research studies which have gone through an ethical board must have what we call GCP, good clinical practice. So it's really an international, ethical, scientific, and practical standard to which all research is carried out to. And you must be compliant with it because it reassures the public that the rights, safety, and well-being of patients are protected and that the data that you're generating is reliable. There's a particular resource if you went on that website that you can learn more about GCP. And in the UK, like I said, you have to have it up to date. So we do that in terms of face-to-face or webinars. And then there's a sort of a mini test you have to do because if you've got your GCP, then you can be on what's called a delegation log for a study. And then you can actually consent for that study and comply with all the ethical regulations. In terms of how to gain study approval, there are different steps, but this is just my very simple overview. It's a multi-step process. I think the most important thing is to design it well from the start. You've got to ensure that it's very robust in terms of what's your question, is your study, if it's successful, etc., will it answer the question that you're out to ask from the start? Statistically, is it appropriately powered? If it's a randomized trial, are you randomizing the right way? And I'd really involve, like I said, statisticians, if you need help with that, and experts in the field. Over here, we always have to have a protocol, so a scientific protocol, which explains the study, what you're doing, why you're doing it, the relevance in the literature. You have to have a consent form and a patient information sheet, and the latter two have to be in a way that, like I said, is simple language, which is not medical and patients can understand. We submit it to our local ethics board, and it's what's called an IRAS pro forma, and then you get approval, which roughly takes 1 to 6 months, which quite a long time in the UK. It's actually a lot less in the States and a lot of European countries. I would also say it's really important to involve patient groups. So in the UK, we have PPI or patient advocacy groups for different diseases. So for esophageal cancer, which I'm very passionate about, you've got groups which are Heartburn UK Association, and they'll be different depending on the condition you're looking at, and getting them to read all this material in advance before you submit it to the ethics board, again, shows that you've thought about your study, you're taking it really seriously, and you're giving it the best possible chance to succeed. In terms of approvals, you have to get local approvals as well, in addition to regional ethical approval. And it's the same if we receive tissue from abroad, we would need that tissue or to have its local approval, but then also have our approval to receive it. In terms of ethical considerations, the UK Research Integrity Office, or UKRIO, also has a code of practice for research, which is quite useful because it's essentially a checklist which divides the ethical process and considerations from before, during, and after. Before, it's important to see if your questions are going to be answered based on your research. Is your design appropriate? Do you have the right skills and resources to conduct the research? Have you conducted a risk assessment? So by that, there might be certain ethical issues where you need an ethics review, or maybe there's certain hazardous procedures that you need to risk assess. Is it legal? And have you complied with not only your country, but all the countries who are taking part in this collaborative research? Have you had the necessary ethics review? Have you got all the monitoring? Because it's not just actually collecting the data, but it's also the ongoing practice of the research and the storage of the data and how you manage all of that. Again, things like intellectual property. So if it's something that you've come up with, which is a novel innovation, then that again has its own legality. And also things like collaborative working. If you're working in a big group, then things like talking about authorships and publications, which will happen down the line. But having these frameworks agreed early on, I think makes part of, again, is another ethical consideration that you must take in account. Conflicts of interest, of course, if you've got any personal or financial gain, you must declare it. And also make sure that you agree the roles of researchers. If you've got a research nurse, if you've got junior doctors, if you're consultants, everyone must have a role in the study so they all know what they're doing. In terms of conducting the research, it's important to see that whether you've set out the design that you set out originally, are you following it? What about changes that have been made subsequently? Do they need further approval or any other review? Are you following the best practice for collecting that data, storing it and managing it, as I said, in terms of your local guidelines? And again, are you continuing to apply audits locally as well to make sure that you're keeping up to date with all of those requirements? When you finish your research, it's also important to think about whether you've, because it just doesn't end in the setting up and doing the actual study, but have you reported your findings as accurately and honestly as you believe possible, and within a reasonable time frame, which has been complicated by the pandemic, but again, something which, so that you've delivered on what you said you would. Have you acknowledged everyone that's taken part, which is, not just the actual authors of a study, but there's often institutions or tissue banks or patient groups, again, that you must, and patients themselves that you anonymously, but you still thank in a publication. Have you sorted out all the agreements for intellectual property, for publication, for authorship? Is your data secure? And you have to think about how long you're going to store it for, because again, for whole genome data, you can secure for many years, but if you have data from deceased versus alive patients, and the rules are different, and they may be again where you are. And does your research comply with all legal, ethical, and contractual requirements? My very simple research rules for success are: you need to ask a good question, something that's going to make a difference in what you're doing. Something that helps patients. You've got to design a really robust study, think big, have a big vision, but your actual experimental design, your research question must be quite focused in the first instance. Don't be shy of asking for help, whether it's from mentors, it's from your local administrators, governance and ethics experts, scientists, statisticians. medical and nursing staff, you've got to, again, have a very collaborative approach to this from the start. You've got to be honest and display integrity at all times, which is sounds obvious, but I think it's really important to always hold that true in your heart. And I think ultimately you've got to have the right intention, because it's all a lot of hard work, but I think we do it because we want to make a positive change for our patients. And that must, for me at least, does sort of underpin the work that I do. And with that, I'd like to say thank you very much for this opportunity. I've really enjoyed it, and I'd be very happy to take any questions if the format allows. Thank you. Hello?
Yeah, if you have any questions for Dr. Noorani, please put them in the chat. Or if you can unmute yourself and ask them now. Before we move on to the next presentation by Dr. Eseenam Agbeko. I can't see any questions for now. If you do have any questions along the presentation of Dr. Agbeko for Dr. Noorani, just let me know or put them in the chat, and then we'll figure out how to get you an answer.
Lovely. Thank you so much, Theo. Have you got any questions?
Pardon me?
I said, do you have any questions or anything?
Myself. It's been very, very clear to me.
Yeah. Thank you so much.
Thank you very, very much.
All right, pleasure.
Dr. Agbeko, the floor is yours.
Yeah, hello, can you hear me? Hello?
Please.
Can you hear me, please?
Yes, please.
All right, so good evening, everybody. My name is Eseenam Agbeko. Like Teddy said, I work in Konfanotu Teaching Hospital in Kumasi, and I'm still technically a senior resident with both the Ghana and West Africa College of Surgeons doing general surgery, and I'd recently completed a fellowship in the UK in vascular surgery as well. I still consider myself a very early person in research. Most of my work is related to palliative care settings so far, and with women with metastatic breast cancer. I think I enjoy doing a lot more qualitative research than quantitative research anyway, even though I believe that both paradigms still, all significantly contribute to what we do in our medical practice. I'll be sharing with you this evening on gaining steady approvals and undertaking participant consent. And my talk is born, should I say, mainly out of things I've learned and the experience I've had working with colleagues, working with senior people, and how I think that they would, you would find them useful with, and particularly for residents who have to present dissertations as part of your fellowship training, and then some of us are taking other basic degrees that require us to do research. And most of my examples would be from the, should I say, the Ghanaian setting in terms of how to be able to get things done here. Oh, why are my slides not moving? Teddy, I'm just going to stop sharing and start again because my slides just wouldn't move. Okay, I'm so sorry about that. Can you see my screen, please?
Yes, I can see your screen. We can see your screen.
Okay. All right. So with regards to gaining study approval, I would just highlight a few things about the study protocol that review boards tend to look out for, and particularly with consenting a study participant, point out things about who you are speaking to, where you are doing it, when you are doing it, how you are doing it, and a few things to always bear in mind. And so when it comes to an institutional board, I think it's always important to know where you're supposed to submit your application. In our settings here, you either have to go to sort of like the Ghana Health Service, IRB, or various hospitals, like in Konfanoche, for instance, we have our own institutional IRB. The university has its own IRB. And depending on where your study is located and which of these bodies that you would have to submit your applications to, or if your study is going to involve people from different settings, then you may have to be submitting your application to these different boards, probably one after the other or concurrently. And so it's always good to speak to the ethics committee within your jurisdiction and know where your study is supposed to go to. Otherwise, you go to one only to be told after some time that, or get feedback that this is not where you're supposed to submit it, all of which takes your time. Know what they want. And I've learned the best lesson is just to visit the office. They are always friendly, and there's someone at the front desk who would be able to give you their requirements in terms of which forms to fill, what to upload online, what you are supposed to submit in written form. If you're doing a study in Konfanoche, for instance, the study will have to be registered in the department in which you are doing it. And the IRB would want to see that certificate of registration as part of the document that you submit. And so you don't want to miss that step, for instance, take your forms there only to get feedback, not even for, what do you call it, like a partial approval or something, but requiring you to do everything all over again, which would be a waste of time. And then know the timelines for the IRB decisions. Some boards here, for instance, maybe will sit every quarter or every 3 months or something. So you look at your timelines and you don't submit probably today, and then the sitting for this quarter was last week. And that means you are going to wait another extra 3 months, or you have to have submitted maybe minimum of 2 weeks or a week before the sitting, and you send it 2 days before, and so you've missed it. So you always have to check all those timelines. And then it's important to just submit on time. Last minutes don't help, and they rush you. With regards to the study protocol, always be clear about your design. Is it just a survey? Are you going to follow people up in the long term? Is it a cohort thing? State that clearly. Who are you? Which population are you sampling? Maybe women with metastatic breast cancer, or all the patients that come into an ED, or people who are probably out somewhere in a community. And this is not about, your sample size calculation. Sometimes people think just having put those things in it makes it enough, but be clear about which group of people, broad group of people that you are looking at to study, and then be clear about the inclusion and the exclusion criteria, who fits and who does not fit. Because there may be two 18-year-olds, and for one reason or the other, just be clear about it and know what it is that you are doing. The sampling method, are you doing just something random? Is it convenient? If it's random, is it some kind of stratified manner or something? You should be able to state those clearly. And then how you approach the patient. I think a lot of my examples are biased to hospital settings because that's most of what I have done. And it's just, I also think that hospital settings are unique in terms of people are entering the space with all sorts of issues. So if there are people coming to the ED, for instance, when are you approaching them? Is it just when they've arrived and they are still probably like in pain or something? Or is it after they have been settled and their treatment has been started? I mean, be clear about all those procedures, because you don't want to create gray areas and then at the end of the day, you are carrying out your research and certain things you are doing begin to appear like you are probably even causing harm or inconvenience to the patient. Not to mention, once you make one patient feel bad or something like that, or you make any potential participant feel bad, you never know where it spreads around. And even the other healthcare staff who tend to be, I don't know, some sort of like gatekeepers to your access to your participants begin to probably not even introduce your study to anybody at all. So you just have to be explicit about how you are approaching them, where you are approaching them, and what you even, should I say, approach them with. Attach things like your participant information leaflet, which is clearly written out in as lay a language as possible for people to be able to understand. And then your protocol would always have to be clear on your study procedures. What is step one? I mean, after you've approached the patient, are you going to come back to them again the next day? Is it the same day that you're going to talk to them about something? Are there samples to be taken, for instance? When are those samples going to be taken? Who is taking them? Once they've taken them, where are they taking it to? You know, it's almost like you are writing it out as if you were leaving instructions for a class 1 child to do certain things when they came back from school, and they should be able to read it and understand it. It's supposed to be so basic and straightforward that anyone and everyone reads it. And at any point in time within your study, they know where what is, who to go to, or something like that. And then the activities to be expected of the participants, for instance, you'd always have to state those clearly as well. So that if it's a longitudinal study, you are going to be following people up, for instance. Have you stated when you are going to call them, how you are going to call them, that what you expect the participant to do? Are they the ones who are supposed to contact you? Are you the ones who are going to contact them? If they are supposed to, what you are taking samples, for instance, maybe urine or anything else, are they the ones to bring it to you? Are you the one going to them to pick it up? All these should be clear. If there are going to be any interventions, if you are administering anything, if you are applying anything to your study participants, all these have to be stated clearly. And especially if they are, I don't know, like medical products, medicinal products and all that, what is the literature about them? Is it something new that you are introducing? And therefore, what is known about it? Like all these things have to be stated clearly. And if there's any added literature that you are supposed to support, make sure that you have provided it. There's nothing like assuming, oh, who knows, maybe though, because it's this kind of study, the people on the board who are going to be reviewing it, they understand this kind of language, and so they would know what I'm talking about. No, you prepare your things as if whoever is also going to be reading it does not know, and you are literally now just educating them about it. Then you would have to be able to list out any anticipated adverse events, how you are going to monitor them, how you are going to mitigate them. And when you are involved in trials and those things, we tend to think of adverse events like drug reactions and all that. But assuming you are doing a qualitative interview and you are talking about some sensitive issues, and it triggers an anxiety attack, for instance, or it causes your participant to get extremely emotional and they break down in tears and all that, what do you have in place with regards to your study to be able to deal with those emotional fallout, for instance? All those things would have to be clearly stated and not taken for granted. I always say, even putting into it something like you are going for each of these, interviews with a box of tissue to hand out to the patients when they begin to cry. Is there another health worker who's probably going to provide some counseling, or is there a clinical psychologist or someone you can refer? I mean, all these things have to come into your protocol because they are not to be taken for granted. Mind you, study participants are, they are like gold, I say. Without them, you don't have any study. And so whatever could potentially go wrong in you trying to understand the phenomenon that you are studying, there has to be clear and explicit plans with regards to how you are going to deal with it. And our stress, again, is not always about the pharmaceutical or the clinical things, but all the psychosocial things that could result as well as part of their involvement in your study needs to be stated, including how you're going to deal with it. And I guess this is particularly important, especially when you're doing qualitative research. Still on getting the approval, I mean, you have to be clear in your protocol how you are going to manage your data, where you're storing the data. A lot of times, I think for student research, or even if you're just in final year medical school or something, certain things tend to be taken for granted, but I believe that it's always better to start off doing the right things right from the scratch, and they become part and parcel of you. So if you're administering questionnaires, for instance, where are these questionnaires being stored afterwards? If you're keeping them on a laptop, where does this laptop get stored at the end of the day? All those things need to be put in, including sound analysis that is going to help you answer or achieve your objective, and not just, right? For instance, what data will be analyzed using Stata 17 or something. I mean, those, I always think that those kind of blanket statements are not enough. And so far as you know what variables you are looking at and how to be able to test associations and whatever between those variables, you should be able to state those in your protocol as well. And then there should be a budget for your study. If you have interventions going on, for instance, even if there are interviews and you're carrying a box of tissue, how much is that box of tissue going to cost you? Because the IRB would want to know that what it is you have written out, you can actually carry it out. Are you going to have research assistants help you do it, for instance? It looks like, I mean, I'm talking really from a perspective of like student work, where you tend to do most of it yourself, but then there are times that you are requiring other people to help you. Of course, if it's a big institutional thing that has, you definitely can't apply for a grant, for instance, anywhere without a budget attached to it. But even if still for the purposes of a student work, you still have to put in some budget with regards to what you're doing, even if it's coming out of your own pocket. How much is this going to cost you? And it's all part of the training and the learning with respect to what needs to go into what, so that after you've graduated from student work and you are now doing collaborative work with other people, you know what you're dealing with. And then timelines, realistic timelines, not that you are probably going to be recruiting your participants in over a month or something, because you think, oh, I just want every adult who walks through the ED door or something like that. And for some strange reason, I've realized whenever you set yourself to do a study, you think there are so many participants you can recruit. And then the very day your recruitment starts, it looks like all those people have stopped coming to the hospital suddenly for no apparent reason, or one just shows up every week. So you need to be able to set realistic timelines. And I can't say it enough that get help when you need it. Nobody just seems to know all of it. And you'll be surprised, friends around you, colleagues around you, who know the part about budgeting. Some know the part about data management and analysis. Some know the part about other thing else. It's ask as many people as you want and you can to get the help that you need. And read, reread, and reread the protocol when you finish, to make sure that you've not made any mistakes or you've not left anything out. And I mean, you don't want to, should I say, irritate some busy person who is looking at your work to approve it with simple things like typographical errors. I think it also tells on you, the individual, and what work you actually want to do. It just doesn't pay to present something sloppy. So, I mean, like I said, again, these are tips from things I've learned from my research experience so far and with working with friends. And I hope that you would find them helpful. Now, with regards to undertaking the participant consent, you want to know who you are speaking to. Are they elderly people? Are they middle-aged people? Are they young adults? Are they teenagers? Are they children? Because that is going to inform the kind of language that you are going to use. We always talk about participant information leaflets, but when you work in settings where people are not English literate, because if you wrote something for them probably in Twi or Ga or any local language, they would be able to read it. But for the purpose of your ethics application, most of these things are written in English. Not to mention, if you work in a very multicultural environment like I do, if you had 50 participants, you can be sure that every 3 of them speak a different language. And so if you were actually supposed to write out participant information leaflet in all these languages, and our ethics committees allow us to, you have one in English and then it is translated to the participant. And so you should be aware of their level of literacy. And I mean, you just can't, just because someone can't read English, for instance, doesn't make them illiterate. So you have to know what they can read, what they know, what level of language you are translating to, what language they speak. If you need a translator, and the translator saying, I mean, being able to translate exactly what it is that you intend to carry across. And I'm very, should I say, passionate about vulnerability, because again, in the hospital settings, everybody who comes in any potential participant you recruit from a clinical setting is a vulnerable person. They are coming, I mean, they have something that has put them in the area where you are recruiting for. And so people come with all sorts of things in terms of, well, let me be nice to them so that they would also help to treat me, or let me just get out. Or sometimes, I mean, they're even so distracted about other things that everything you're saying, they're just nodding anyway, because some may even misconstrue it, even if they know that the research is not part of their treatment. But so far as it is still within the clinical setting, they are friends, they know each other. So let me be nice to them so that they also get nice to me, or something of that sort. Always be sensitive to that patients that you recruit in clinical settings are vulnerable. And therefore you don't, I think saying, keep using the word taking undue advantage would be harsh. But I mean, all I just want to say is know that they are different from the everyday person walking on the streets, holy and jolly, and have presumably everything around them to be able to make that informed choice. If you are recruiting in a clinical setting, they are compromised one way or the other. And so be mindful about how you present information to them with regards to getting them make an informed consent. And then where this is done, in public hospitals in Ghana, for instance, I mean, people in a public space, people don't have like private rooms or something. We have issues with congested ED, emergency departments, congested wards, and then you are taking consent for a study. Some of the things you are probably telling the patient about are, sensitive sort of things that you are mentioning. How do you ensure privacy? Do you need a witness to be there? Who is this witness? Is a witness another healthcare provider, or is a witness even if it's another healthcare provider, but far removed from the patient's treatment or anything that they ever come to the hospital to do. Because like I said before, you don't want them to associate their agreeing to be part of the study as, you know, something that may be tagged to their treatment one way or the other. And then I put audience because of the congestion around. You're speaking to one person, someone else is listening, that sort of thing. And so for the purposes of undertaking participant consent for research, you have to be mindful of these. I like this cartoon thing I picked from study.com. What you tell me will not leave this room. Meanwhile, in this room that we are, there are so many other people around. So we'll not leave this room with respect to, I am not telling anybody, but everybody else is listening. So these are things that you need to be mindful of. And then with regards to how, we always write excellent, you know, participant information leaflets, okay, with everything in lay language. But I always say, if you've consented, if you've given a patient information about a study, you consent them, and an independent person went to ask them, what have you been told? What have they said this study is about? And the patient cannot, you know, roll out all that information nicely in a chronological order with regards to what it is you intend to do, then that information really has not been successful. You have not effectively communicated to the patient how or what it is that you intend to do. And this is particularly important if you are doing a longitudinal study. You are going to be following people down the line, and patients, the participants don't know that you call them back in 3 months' time, and so they change their phone number. Or they don't know that in 3 months' time, you would have wanted to meet them at, say, point X or Z, or they coming to the hospital, and then they don't show up, or they don't meet you wherever they are supposed to. Imagine, that's going to be a very high attrition rate for your study, and therefore it's going to affect your eventual analysis and what you are doing. And if at the end of your study you can't get anything out of it, you've wasted your own time, you've wasted the participants' time as well. So it is not just about writing something, writing a good participant information leaflet. Think of it with respect to how the participant, either having read it themselves or having had someone read it to them or translate it to them, be able to understand it as clearly as you do from your, scientific perspective, that this is what this study is about, this is what is expected of me, and this is how we're going to go about it. When to take consent, there's one consultant I'd worked for before that if a patient was going to have any complex surgery, he would take the consent. In fact, he will tell you about the surgery in one clinic visit. The next week you come back, he gives you the consent and you sign it and everything, and you take the consent with you home. And then the third week, you bring the consent back that, oh, probably I'm ready to do, or even if it wasn't a weekly thing and it was every 2 or 3 other days. But his thing was, he wants the patient to be able to really reflect on what it is that is going to happen, the morbidity and the mortality risk and all those things that come with it, to be sure that this is what he actually wants to undertake. Many a times we probably just give the information, especially for surveys, you're giving the information at that time, the consent is signed at that time, the next thing they are answering the questions. I'm not saying that that cannot be done, but I just want to point out that you need to reflect on these things and know that you're actually achieving your purpose of having an informed participant. They understand what you are doing before you undertake the consent. And again, in clinical settings where people have come with all sorts of pathologies, they are in various states of health and all that, and how they process information, you want to watch out for these timelines and know you are being effective. And it's much so if you are doing like trials, for instance, where in Ghana, the Food and Drugs Board, or the Food and Drugs Authority would visit your facility at random, and sometimes pick some of your participants at random, or call them at random and ask them, you are involved in this trial, what is it about, what are you doing? I mean, you don't want to be caught on the wrong footing with regards to things like this, because the FDA in Ghana is really tough. And if they caught you on something like that, that would really be trouble, not just for what you are doing, but all your other subsequent trials. And then what constitutes the consent? A thumbprint, a signature. Make sure that it is on the consent form and not, oh, I'll come back and do it later. Because if someone pulled one of those out randomly and it turns out to be there, I'll come back to do it later. What is not documented is not done. And our witnesses needed, especially either underage people or, again, we're saying in the clinical setting, they're always vulnerable patients. And so if a witness is needed, make sure that that is done. And then always note that a participant can withdraw their consent. Of course, for as long as the data can be traced to them anyway, because at a point in time, you anonymize everything, it just becomes a mumbo jumbo of numbers or something, but let them know that this can happen. And in fact, I have, during my PhD research, it was these women with metastatic breast cancer. And one woman had told me that in the course of, I was audio recording the interviews. And so she didn't want, she was also about, I probably put a recording on a radio or something. And so we spent a lot of time going through that. But she eventually agreed to do the interview so fast. I didn't mention her name anyway, anyhow, in the course of it, and just refer to her as Madam. And then I have a, should I say, sticky habit of always addressing people by their first names or a formal name, because I think that that is, I mean, what to do. So somewhere in the middle of this interview, I did mention her name, and that was the end of it. I had to erase everything on the tape. I had to shred the consent sheet. I mean, I had to shred anything traceable to her with regards to the study. And these were participants that were taking me ages to find somebody who fits my inclusion criteria. And so it was a very painful experience for me. But then it's something that's always reminded me of, it's your participant. They decide when they want to be in it, when they don't want to be in it. And you must be aware of that as a researcher and grant that. And also, I think I've mentioned before that our participants really are like gold. Without study participants, we have no research. And I found this quote on anikiquotes.com, which I thought just said that when I give you my time, I'm giving you a portion of my life that I will never get back. So please don't make me regret it. We undertake studies, I mean, for academic purposes to, yes, we want to gain knowledge. We put this knowledge back into practice and all that. We find things that transform medical practice. It's been in the past and it continues to be, and all of us are contributing to that dimension of work. But always remember that the people who give us their time and things about them for us to gain the knowledge and the advancements that we have are special, and we shouldn't take them for granted. So in conclusion, I mean, I've been through how to meet some IRB requirements and how to consent participants. But foundational to all of this is being organized. You need to set your things out, plan things. Don't take anything for granted, even if it means writing it out on a board, on a what do you call it, on a wall or something, and taking out these activities one after the other as you are doing them, just so you make sure that you've not missed any step. And no study is too small. You know, don't think of something as, oh, this is some student's work or something. You learn the right things right from the beginning, and they become a part and parcel of you for the rest of your research or career life. So that's it for me. Thank you. And I'd like to acknowledge Dr. Joshua. Dr. Joshua is my, well, I call my research buddy. We do a lot of work together, but he's the head of public health unit in Komfo Anokye and has been the project manager for NHR trials that we've run in CAT, and we put this together based on our experiences of having worked together for 22 years now. So thank you very much.
Excellent. Thank you very much, Dr. Agbeko. This has been really enlightening. Thank you for also giving your time to us in a part of your life, and hopefully you wouldn't regret it. We have a number of questions. I'm just going to read them. The first question is there any specific fee to pay for study approvals?
Yes, there are fees to pay for study approvals in, at least in the IRB settings that I know in Ghana, and how much you pay depends on what kind of research it is. I think for most students, researchers, the ethics application is free, but if they are grant related works, I think the fee is even tagged to what the grant money is. I think the KNUST IRB, for instance, if you go through their requirements, depending on how much the grant is and whether it's a local grant or it's an international grant and all that, all dictates the fee. But for student work in KNUST, I think the application is free. I don't know, at least that was the last I checked. I don't know whether it's been changed now, but to register studies in the various departments in Konfanoche, for instance, I think for the departmental staff, it's also free as well. Yeah.
Okay, excellent. The next question is, if you've already submitted your research and it has been approved for publishing or publication, can the participants still opt to withdraw them?
So that's where I mentioned withdrawal would have to, I mean, people require that you set limits for when they can withdraw. Let's say you did a study and you are looking at people, some anthropometric measures like height and weight and those things. And at a point in time, I mean, once you've collected it, entered it into your data management system and all that, you now take out every, what do you call it? Any identifiable data, right? So if you have two weights that are 50, are you able to tell whether it belongs to A or B? So it's usually up to the point where you have, if you have not anonymized the data yet, then they can. But beyond a certain point of analysis, I think that becomes difficult for you to do. And if from your question, I'm believing that this is work that you have written up, sent to a Viva or something, or you mean you have submitted it to a publishing body and they have, what do you call it, approved it for publication. I guess that may be way too far down the line, unless someone else has any different experience they want to share.
I think that's the question. Basically, it's been peer reviewed and is not accepted for publication. Probably too late.
Yeah, then. So if you've analyzed, because then that would mean you have to withdraw the paper then. And that is if you put within your consent that the participant can withdraw at any time. And so you must bear in mind it's a legal document, and what information you are putting there, I don't know, you would have to watch what words and what terms you are using. Because if you leave it as an open statement without any cutoffs, then yes, legally the participant has a right to say I'm no longer part of it, right? But if you have said maybe up until the point where everything is anonymized, or up until the point where the work is submitted for publication or something, then once they are telling you that afterwards, that's not to, I mean, forget that. It's not like you tell after you've done a research, you tell them that I'm going to publish it in June or July, right? So how do they also know that that is what is going to happen? But I guess the foundational thing is to be explicit about when something or when they have a right or something to do otherwise. Yeah.
Okay. The next question is, please, how comprehensive should the budgets that's attached to the protocol be, especially if you are self-funding or the research doesn't need much monetary funds?
Well, I mean, much is relative, isn't it? Or even if you are self-funding, if you are going to print out questionnaires, for instance, you are going to buy a ream of A4 sheets. How much does that cost? You have to put it in. You are going to print maybe the first sheet and then photocopy the next. How much does it cost? With what do you call it? A percentage of all your budget costs for miscellaneous. Do you plan to, are you going to travel to, what do you call it? Are you going to travel to meet the participants or something? How much does each journey cost? You would have to put those things in. Because mind you, I mean, these ethics committees have been doing this thing for years. And so they can read your protocol and begin to pick what kind of activities you are going to be doing. And they're going to ask you, how are you going to sponsor those activities? And no one is going to approve a study for you when they think that you are not probably going to be able to carry it out, and you would end up cooking things to write up. No. And so it is of course, you may not put something in like, well, those things actually fall under your miscellaneous. Like if I went on the field trip, I'll buy a bottle of water or something. You wouldn't put a bottle of water per each trip. But that's why there's a section of your budget that says miscellaneous. I think which tends to be like, is it 10% or something of everything you've calculated? And everybody knows that, assuming some of the papers you printed, there was a mistake, you are going to photocopy another one. You're probably going to buy a bottle of water, all those things. But every significant activity in your research work that is going to require something to be done should have cost attached to it. And if somebody is doing it for you pro bono, you probably also, it will be helpful to mention that.
Okay. A couple more questions, and then I think someone raised their hands out. If you are here after these questions, you can just ask your question. So the first one I wanted to ask is, do you routinely have a mechanism in place to de-anonymize data you've already collected? Is there like a master person where if at some point a patient wanted to withdraw, even after anonymization, do you have like is it routine to have that system where you can de-anonymize data and then take them off?
Yes, so that's, if I get your question right, you mean I've now anonymized everything and then the participant wants to pull out. Is that it?
Yeah, yes. Do we routinely have like a mega database where we can actually de-anonymize the data we've already anonymized?
No, Teddy, I'm getting confused.
So you've taken some data, you've anonymized it, and you want to analyze it. I'm asking that, is it routine? Is it routine that anticipating that somebody might withdraw at some later stage, you have like a backup where you can actually de-anonymize data and then take those participants off?
Okay, so from personal experience, I create various data sets. Not that I've worked with any large numbers, okay? Because with regards to de-anonymize, come back to be able to find it, it's always an individual that sets the system up, isn't it? So if, say, I have maybe 100 participants and I've now giving them serial numbers or some codes or something, I would always still have a system to be able to track which serial number came from which data set. And especially because when you've de-anonymized and you are cleaning and setting places, some things are ambiguous and you need to go back to the original raw data. So I'm able to do those kind of cross-checks and know where what information came from. However, I think that the reason why we set limits for when a patient can pull out of a research thing is you don't want to calculate a mean or some measures of central dispersion for a population of 100, and then next week 2 people come that they don't want to be part of it again. So now your sum becomes 98, and the next week another 2 come that they don't want to become. It's just like, I don't know whether using this analogy, for instance, would be appropriate, that goods sold are not returnable in certain shops, or beyond a certain time, you cannot return it. It's not like we don't know that, yes, you bought it. We'll be able to get the receipt and everything and track it. It's just that you've gone beyond the time where you can come back and say that I don't want the item anymore. So it's the same thing for me with these research things. Yes, I always have a system set up where I can always trace anything if I want to. And I guess probably it's because I've worked with small numbers, also with qualitative research and all that. So you can always track certain things. But to be able to keep your sanity as a researcher as well, you have to set limits. And so yes, having a system where you can trace your data back and be able to correct things or get the right information back from the original set is right. But with respect to when a patient can pull out, I think that you need to be able to set limits. Otherwise, you probably never finish your work.
Okay, thank you very much. And there's a question here that says that if there are unforeseen circumstances that make your cost of your study exceed the budget, I presume this is after you've submitted your protocol for acceptance. Let's say there's a sudden rise in fuel prices, causing the study to exceed the budget for, let's say, transportation. What do you do?
So as much as possible, there shouldn't be unforeseen circumstances, because you would have thought and rethought through your study procedures and everything before you finished it. However, yes, things happen. COVID will come, there's a tsunami or something, there's a flood and it takes away your computer. Technically, you are supposed to, or the thing is to write back to your ethics committee. Because whenever anything changes about a study, you have to write back to the ethics committee as, what's the term for this thing? It's not to update them, but if there are any amendments, exactly, if there are any amendments to your work, you have to write back to the ethics committee to let them know. And actually, at the end of the study as well, you have to write back to the ethics committee to let them know that the study is finished. So unexpected things can happen. Sometimes these unexpected things may even mean that the study has to be closed, you cannot continue it anymore and all that. You would have to write back to the ethics committee to let them know.
Okay. One last question. If you are carrying out a project that is multi-center, for instance, do you need to get ethical approval at all the centers? So for instance, you want to carry out a project in Kolebu, Konfanochi, and say Tamale and Cape Coast Teaching Hospital. Do you need to get study approval at each and every one of these facilities, or does one cover all?
No, so each institution has its review boards and all that, isn't it? So yes, you would need to seek approval from all of them. But that takes me back to always talk to your IRB, because they may say, for instance, that if you took there may be situations where if you have, let's say, a Ghana Health Service, an approval from the Ghana Health Service IRB, for instance, then it may be a matter of submitting those approvals or whatever to your institutional IRB for them to know that such and such a thing is going on. Because you can't run a study within some ethics jurisdiction and the people there don't know that something like that is going on. Because if anybody were to notice something about that study and went to report to them, and there's nothing like that in their records, that somebody is collecting such and such a data, it is highly inappropriate. And so yes, you would have to seek approval from each institution where you are and the appropriate approval for that. There are some places where if it's just, should I say, an audit of clinical data or something, the process of getting an approval is completely different from if you are doing some interventional study or anything of that sort. So I remember, I think one of the NHR trials that we did, was it Cheetah, for instance, the CAT IRB wanted FDA approval. And yet in other institutions, their hospital IRBs didn't want that. And so, I don't know, eventually the national office had to get an FDA approval because that was the only way we could run that in Confanoche as well. So you would always have to get a local approval as well.
All right. Thank you very, very much, Dr. Agbeko. Thank you for taking the time to share with us your experience, and we are very grateful. If there are any announcements, Dr. Dorcas, do you want to tell us before we bring this meeting to an end?
Okay, thank you everyone who joined us for today's meeting. Our next session for the next webinar, that's the fourth webinar, will be in June, and it will be offered by Professor Anson. It will come on the 25th of June, 2022. Sorry, 24th of June, 2022. We hope to see you all doing that webinar.
And also, for those on a systematic review track, I think the deadline for going through the course from Johns Hopkins is on the 31st of May. If there are any challenges, or if you have any problem with the timelines, please put them on the pages and then we can discuss that. But we want to really stick to the times we have set for the project. All right, thank you all very much for coming for this meeting, and hopefully see you next month. Thank you, Dr. Agbeko. We are really grateful.
Yeah, thank you everyone. Have a nice weekend.
Dorcas.
Yeah, what's up?
Dorcas, you had a question for Dr. Ayesha. She said if you message it to me, I would send it to her.
I was asking about the good clinical practice, just for the other, because she mentioned it. I wanted just to know how people could subscribe to it.
Oh, okay. I think there's a link. There's a link, a free link by an organization. I'll look for that link. We can just share it alongside the link to the recording to all those who came.
All right, okay, that's fine.
Yeah.
I think we can stop the recording now, isn't it?